Greetings everybody, I'm Anjali Sharma from the Center for Infectious Disease Research in Zambia, presenting on the ACCHIVE study, which is Advancing Cervical Cancer Screening in HIV Positive Women. I will take us through the background, research objectives and questions, the methods that we used and what we found, and conclude with recommendations. As you may be aware, we are in the midst of two overlapping epidemics here in Zambia. About 15% of our women have HIV, out of whom 90% have high-risk human papillomavirus variant. Cervical cancer kills more people than any other cancer in Zambia, meaning more women are dying. However, effective cervical cancer remains under 5%. There are many reasons for low cervical cancer screening service uptake, as described by Onyanveni and Mchunu from Nigeria. Suffice to say, these reasons have to do with access, affordability, availability of time, literacy, and then prevailing socio-cultural, psychological factors as well as gender norms. All of these can conspire together to lead to refusal to test for cervical cancer, as well as influence decision-making for care seeking. So we sought to explore the facilitators and barriers through the different steps that must happen during cervical cancer care from both women and healthcare worker perspectives. We wanted to see what was care seeking like among women with and without HIV in Zambia, the influences on this practice, and the experiences of those who were screened. The study was conducted in Lusaka here in red, as well as Eastern Province in brown, with the circles roughly denoting the areas from where we collected data. We talked with women in the general population, either from their community or ART clinic, irrespective of whether they had been screened or not, as well as those from cervical cancer clinic with or without lesions. We also talked to healthcare providers from facilities that provide ART or antiretroviral therapy services, whether they had cervical cancer services or not. The study was conducted in Lusaka urban, Chipata, which is peri-urban, and Lundazi, which is rural. We talked to 6 healthcare workers in each of these areas for a total of 18. In Lusaka, we also had an FGD with healthcare providers from ART clinics with or without cervical cancer screening. In the community, we had 1 FGD in each of these areas. In Lundazi, the group was not screened. In Lusaka and Chipata, we also talked with women who had been diagnosed with lesions, and then we had 3 groups in Lusaka with women without lesions and 1 in Chipata of the same. There were many reasons given for why one gets cervical cancer, and though these appear to be siloed and can be divided sort of into biomedical or practice or traditional beliefs, they remain interlinked. So for example, if my spouse is promiscuous, then it's possible that his lover practiced witchcraft, and that's why I ended up with lesions. Because of these beliefs in disease causation, care seeking can be delayed because you would prefer to go to a herbalist to take care of witchcraft, for example. Those who are defaulted on ART would also not return because then they're afraid that they would be put back into ART care. Care seeking is prompted by severe symptoms, for example, prolonged periods, smelly discharge, pain during sexual intercourse, and severe or abdominal pain. You may also be influenced by social media. For example, there's a support group called Teal Sisters on Facebook, or it's what you see happening around you which may prompt you to seek care. So some might say, if I don't have pain, then why should I go for screening? Another might say, I'm okay and I don't want to know whether I have cancer or not because cancer is incurable. According to a healthcare worker, somebody might say, people believe that because I'm a Christian and I'm spiritual, I can get relief or healing from my pastor or my prophet. And others believe that anything to do with your genitalia is witchcraft. So the best is to go and see a herbalist. Then it doesn't work. Then they will come and see us. Finally, there are examples where somebody like an elder sister may advise that one should get screened and that it's better to get screened and treated earlier, otherwise the consequences can be quite severe. So we found more barriers than facilitators through screening, follow-up, and diagnosis and treatment. Some of these reasons have to do with poverty, if you're too poor to access, or you may be too embarrassed to talk about something around your genitalia. You may prefer to self-medicate or go for herbal healing or spiritual healing. Maybe you don't have enough information, or maybe you've heard that you can't have sex for more than for about 6 weeks, or that the speculum can hurt. It could be that you are afraid of the cost. You've heard that it can cause barrenness or even death that may come with cancer. As we are not quite decentralized, there are particular clinic days. So if you come on the wrong day, then you may have to come back, or it may be very crowded and you don't feel safe around men who are there as well, or it could be a long waiting time. And there's some rejection of HPV swabs as well. Fear of cervical cancer and HIV status can either lead you to care or can get you away from care, as explained earlier. With follow-up and chirotherapy or LEAP, the reasons are similar. You find that if you cannot get LEAP where you were screened, then you have to go to another area, and that you may not be able to do because of poverty, or you're lost between the referral and linkage and follow-up services, or the post-procedure requirements do not work in your life, or your results may be delayed or lost. Similarly, if you have to go for a biopsy or for treatment for cancer itself, the same conditions apply of poverty, poor referral and linkage. Maybe there's a reliance on private labs. There's a long wait for the results, or they are lost. Side effects are feared. And then there's anticipated pain of the biopsy or the treatment itself. So there's some suggestion that the staff themselves need training both on giving information as well as being able to refer. Also, women may come for a specific symptom and think that they would only be given medicine, and yet they're asked to go for cervical cancer screening. And since the procedure requires the woman to be naked halfway, some will say no. They haven't shaved because they were not prepared. They feel shy. Also, while the government provides screening, the results themselves may not come. They may be lost. They may take a while, such that somebody may even be dead before those results come. As we said, poverty is really a big part of this story. This is one participant saying how she just did not go back because she knew that when they took the sample, she would have to pay for the transportation. So she went on to say, that's why I refused and lost hope, that I don't have any support because I'm just alone. My husband is late. The money is going for the school-going children. If I go somewhere apart from Chipata, they will tell me to go to Lusaka. Where am I going to find the money? There's no one to help me. So I told them that if I'm going to die, let it be like that. There's also a success story. For example, another participant in that same FGD said, look, they screened me, they treated me, they gave me medicine, and yet when I was feeling pain, I went back to them for a laser beam procedure, and she has felt good. She has come back 3 times, and she knows that the problem is solved, and she wanted it solved because otherwise she would have died. And she gives the example of her elder sister with whom this happened. Her her sister's care was delayed because they used to call the brother, who's a reverend, and she was almost dead by the time she was taken to the hospital. So for this reason, she went and accepted the treatment. And she says, I told them to do what they want to do until the whole course. So now they're telling me I'm just okay. We are moving together with the health facility. So on the left of the screen is what should happen. However, in real life, what happens is that the treatment or the follow-up from VIA is most likely to happen for women with HIV. If they are referred to a clinic for a LEAP, then they may be lost because they are not able to afford the movement, or they're embarrassed, or they have fears, or they have to ask permission from their husband. Similarly, if they are suspected for cancer and have to go for diagnosis, they can be lost to the system. If they do make it to a biopsy, the sample may reach a private lab or a public lab. Depending on the results, they would be referred to the university teaching hospital. And all along this way, there could be a drop-off, which finally results perhaps in death. So the gaps were the lack of correct information, lack of training or fewer staff trained, poor referral and follow-up systems, lack of integrated services, lack of access to funds for storing and testing samples, long waiting times, and lost biopsy results. I will stop here with acknowledging our team from CIDRZ, the University of Basel, and the Ministry of Health. And of course, you are our audience and our participants. Thank you.